The following podcast is part of a certified educational activity titled Leading the Next Chapter of Myeloma Care, Oncology Nurse Stewardship in the Era of Innovative Antibodies and Cellular Therapies. Access the entire activity and complete the post-test at peerview.com/ZNS860. Downloadable slides and practice aids are also available.
Hello, this is Beth Feynman from the Cleveland Clinic Taussig Cancer Institute in Cleveland, Ohio. I'd like to welcome you to Leading the Next Chapter of Myeloma Care, Oncology Nurse Stewardship in the Era of Innovative Antibodies and Cellular Therapies. Today, I'm going to share core nursing principles for multiple myeloma care with a focus on major advances with our best tools focusing on CD38 monoclonal antibodies, B cell maturation antigen or BCMA directed therapies, and non BCMA immunotherapy. Throughout, we'll look at best practices for dosing, safety management, care coordination, and logistical planning with many of these therapies. We've also prepared several practice aid resources that summarize these considerations, so you might want to download those resources now. So let's begin. Here's what you'll learn today. CD38 antibodies can be safely delivered as part of a 4-drug regimen in newly diagnosed multiple myeloma, including for older patients. Planning for referral and safety considerations can help facilitate early use of CAR T cell therapy. BCMA antibody drug conjugates may once again be available to our patients and offer an alternative treatment pathway for some patients with relapsed refractory multiple myeloma. And bispecific antibodies are effective options in relapsed refractory multiple myeloma that can increasingly be delivered in the outpatient setting with attention to dosing, infections, and cytokine release syndrome. Here you can see a timeline of progress in the developments with the CD38 antibodies, and it starts in 2015 with the approval of daratumumab and elotuzumab in November 2015. Then by 2020, we had new ways of giving daratumumab in a subcutaneous fashion. We also said isatuximab was approved in March of 2020. In 2020, interestingly, belamaf or belantamab mafodotin was FDA approved. This is an antibody drug conjugate, and then unfortunately was withdrawn from the market in 2022. But in the meantime, in 2021, we had more ways of getting the CD38 combinations with pomalidomide and dexamethasone and carfilzomib and other drugs. And we also had an expanded isatuximab induction. We also had some additional progress with the quadruplets, BCMA and non BCMA immunotherapy, as you can see on this slide. CAR T cell therapy, BCMA, GPRC5D times CD3 bispecific antibodies. Those are the teclistamab, elranatamab, and talquetamab. In 2024, we had different indications as well for the ide-cel and cilta-cel CAR T cell therapies in earlier lines of therapy. And then in 2025, we had the reappraisal of belamaf as well as the approval of linvoseltamab in the European and US markets. Also in 2024 and 2025, we saw the emergence of quadruplet regimens such as Perseus and IMRAS studies in newly diagnosed myeloma patients. Unfortunately, despite these advances in therapy, progress in multiple myeloma has been lacking. For many reasons, patients will not necessarily get what we now consider to be the best therapy, a quadruplet therapy with an anti-CD38 monoclonal antibody. Bortezomib, lenalidomide, and dexamethasone is in the NCCN guidelines and should be recommended for all patients, regardless of transplant status, in the newly diagnosed fashion. This Flatiron Health analysis of electronic health record derived data shows us that from 2016 to 2023, mostly in community clinics, 1,500 patients weren't getting that gold standard therapy that we now know helps keep patients in remission longer. We also saw that after the one prior line of therapy, patients were falling off. Attrition, they weren't getting a second or a third or fourth line therapy, and further, their outcomes were compromised. So, the take home point on this slide and this analysis is to try to use your best therapy early and try to support our patients on that. So, a partner in this program is HealthTree. I'd like to invite you to let HealthTree help educate your patients on some of the complex discussions that we're going to have today. We have experts such as Dr. Ben Diamond, Dr. Natalia, and Dr. Joshua Richter, who are experts in this space as well. Patients are have a good voice in their care, and it might be hard as a community practitioner to know what to recommend them on, but HealthTree is there for them, and I'd invite you to recommend this website and have them opt into learnings. Further, HealthTree is building a nurse advisory board. They're creating a dedicated space for nurses who are passionate about blood cancer patient care to access treatment and research collaboration. So stay tuned for more information on the HealthTree Nurse Advisory Board, and this might be an additional opportunity for you to learn more about myeloma. So let's go into the next part of our program, setting standards, core nursing principles for patient care in multiple myeloma. So I set the stage for the newer chip therapies. Let's take a step back and talk about what is multiple myeloma. Multiple myeloma is a cancer of the bone marrow plasma cells. Plasma cells live in the bone marrow and they have a very important immune function to make these Y-shaped antibodies to protect you from getting sick. Unfortunately, the derangement in that structure, it has excess heavy chains such as IgG, IgA, or IgM, and then it can have an excess kappa or lambda. And so we'll talk about how to diagnose myeloma in a moment, but that overproduction of one clone of a monoclonal protein can affect blood cell production. A lot of people will present with anemia. It can lead to weakened bone structure, pain, fractures, osteoporosis, and other complications such as kidney disease or other organ damage. So it's important for nurses to know what to test and when. It's a puzzle to put all the pieces together. We start with the laboratory testing, then we need a tissue bone marrow biopsy, and then radiologic imaging to determine, does this person have multiple myeloma? How much of a monoclonal protein do they have? Do they have any organ damage? And these same tests are tested throughout at regular intervals, depending on the patient and what therapy they're on. Usually, it's about every month you'll check the monoclonal proteins, especially early on at the newly diagnosed stage. But the common test that we look for is a complete blood count. It's a window into your bone marrow's ability to make healthy cells, looking for anemia, white cell abnormalities, or low platelets, looking at blood chemistry tests such as the organ function, kidney function with the creatinine, liver function, as well as hypercalcemia. Make sure that the serum albumin is a normal level. That's a surrogate marker of IL-6 production, and the IL-6 gets is overactive in myeloma that's active. Quantitative immunoglobulins, how high is the IgG, IgA, or IgM? How high is the kappa or lambda? What's the difference in the kappa lambda ratio? And then also the monoclonal protein analysis. Does your patient have an IgG kappa or an IgA lambda type of a monoclonal protein that we need to monitor throughout? And they don't change clones over time. And that's an important point to just know what kind of protein they have. And then that's what we're going to monitor for their disease assessment and looking for relapse. The bone marrow biopsy gives us such important prognostic information that immunohistochemical staining will look at the CD138 positive plasma cells. Do they have too much kappa or too much lambda? Again, that's the clone of the normal protein that we need to watch over time. The flow cytometry will make sure there's no other abnormalities. The cytogenetics of the cell, the brains of the cell, the DNA, the paired chromosomes. Are there any abnormalities in those as well? Again, it's not the patient abnormalities, it's the clone of the myeloma abnormalities in the bone marrow. FISH is a test called fluorescent in situ hybridization analysis, and FISH findings are super important for prognosis. This staging system for high risk myeloma, or the classification system, was just updated and a joint venture for the International Myeloma Society and the International Myeloma Working Group in June of 2025 that suggested the high risk clones. It's more about how much of the high risk clones were there, such as deletion 17p, gain of 1q or amp of 1q, and then the standard risk trisomies are 11, 14, and 416. So if you want to learn more information about that, there's lots of publications out there we can share with you. And then finally, radiologic imaging. We discussed earlier on that the myeloma protein can invade the bone marrow space and it causes disruption of the osteoclasts that nibble away at bones and the osteoclasts that rebuild bones. And that imbalance of the osteoclasts and the osteoblasts leads to bone loss, osteoporosis, and fractures in our patients. So we want to look at the whole body. Whole body low dose CT scanning is the one of the gold standard tests that the International Myeloma Working Group recommends, as well as the PET CT scan to look for osteolytic lesions. Sometimes we look at the MRI of the spine or a CT of the spine to look for osteolytic lesions. We used to just do a plain skeletal survey, but studies have shown that you can miss about 40% of osteolytic lesions because it's just plain radiographs. It's not as sensitive to detect the damaged areas of bones. And so now the better screening and testing, the whole body low dose CT, PET scan, MRIs are what's recommended. So think about your patient who presents with a little bit of anemia. You're seeing them in the clinic, maybe as a nurse or nurse practitioner. We want to determine, does that patient need treatment. Far and away, the most common diagnosis is MGUS, monoclonal gammopathy of unknown significance. That occurs when a patient has a low percentage of bone marrow plasma cells. If you check the bone marrow biopsy, a low M spike in the blood, those patients tend to have a low risk of needing treatment, especially if they have an IgG or kappa type of a monoclonal protein, but they still need to be watched about every 3, 6, or 12 months, depending on how high the protein is. The smoldering myeloma is that second phase. Smoldering myeloma patients have a higher percentage of bone marrow plasma cells, usually 10 to 20% in the bone marrow space, and then they have a higher number of kappa or lambda cells or a higher M spike. Now we have this 2220 scoring system. There's several scoring systems out there for high risk disease, but I like the Mayo Clinic's 2220, and it looks at an M spike of greater than 2 grams, clonal bone marrow plasma cells of greater than 20%, and also a difference in serum free light chain ratio of greater than 20%. Patients who have high risk smoldering myeloma are now recommended to be considered for treatment with daratumumab or lenalidomide. So, again, getting to a specialty center, if this isn't your specialty care, might be something to consider. And then finally, the malignant stage. We use CRAB. CRAB is the criteria that stands for the acronym hypercalcemia, renal insufficiency, anemia, or bone damage. Those patients have multiple myeloma that requires treatment. If they have that slim, the 60% bone marrow plasma cells greater than 60% or greater bone marrow plasma cells, the light chain ratio that's higher than 100, or osteolytic lesions on MRI, those patients should be considered for early intervention if they don't have a lot of organ damage. So now we're making the diagnosis of myeloma, and we have to think, okay, as a nurse, what do I need to know about taking care of these patients? Well, we already mentioned the PrAB, the hypercalcemia, renal insufficiency, anemia, and bone disease. So R is the first one. Avoid renal toxic agents. CT scans with dye, like if you're worried about a blood clot in the lungs, we want to do a VQ scan versus a CT contrast test because ionized contrast dye can be very hard. If they have a GFR less than 30, we want to consider, does that person need antibiotic or antiviral agent dose reduce? Or as well as their other medications. We know also a VT is increased risk for our myeloma patients. It's a cancer of the bone marrow plasma cells. Plasma cells are proteins, and proteins are sticky. So, along with high levels of proteins are sticky, and then the other blood clotting components in the blood, patients are at an increase of blood clots. I use the IMPEDE VTE risk score in my clinic to make sure, are they on an IMID? Are they having a major surgery? Do they have carfilzomib? And we assign a risk score. So everybody should be at least on a baby aspirin if you have a myeloma diagnosis on lenalidomide or carfilzomib. And if you're on both, then we want to consider, do they need a direct oral anticoagulant or warfarin, depending on their kidney function, to protect them from blood clots. GI complications can occur from the disease or from the drug therapy. And so look for diarrhea and constipation as a nurse. Ask them if they're having these side effects. We use cholestyramine for lenalidomide, induced diarrhea, bile acid sequestrant. And then also newer therapies, which won't be discussed today, such as selinexor, can cause a lot of GI side effects. And so keep that conversation open and ask your patients to share what kind of side effects they have. And then both health changes. It's recommended by the International Myeloma Working Group that everybody take a bone modifying drug, either zoledronic acid or denosumab, to protect their bones for at least 12 doses, and then sometimes intermittently, depending on the patient and their skeletal risk. We give these drugs to decrease the risk of fractures, and so making sure you know your patient's risks are there. Thin white female over 40 who already had osteoporosis, now they have myeloma, or are you a fit, healthier guy that lifts weights for a living? And so, again, stratifying your risk is important, but take home point is that everybody with myeloma, 85% at one point in time can have damage to one's bones. So, protecting them, encouraging weight bearing exercise, as well as other calcium and vitamin D intake is important. So, when we're considering nursing strategies for management of patients with multiple myeloma, we want to also consider infectious diseases, cardiovascular complications, neurological effects, and the importance of health maintenance and disease monitoring. So, infectious disease we're going to talk about later on with the bispecific and CAR T cell therapies, but we want to assess for infections, make sure they're up to date on immunizations, and shingles prevention is super important. In terms of the cardiovascular complications, myeloma doesn't affect the heart, but some of the drugs do. If they've been on cyclophosphamide, high dose melphalan, or if they're on carfilzomib, it's really important to monitor their blood pressure. And I always like to get a baseline echocardiogram and EKG on all of my patients just to make sure that their left ventricle is functioning well. And also, cardiac amyloidosis, which is a cousin to multiple myeloma, misfolding of the light chain can attack the heart. I want to make sure that they have a good functioning heart. In terms of the neurologic effects, we know bortezomib is widely used and it's a very effective drug. We used to see a lot of peripheral neuropathy with bortezomib back in the day when we gave it IV days 1, 4, 8, 11, and we've kind of gotten away with that dosing schedule and see far lesser neuropathy with the subcutaneous fashion that we give now. But make sure you're asking patients if they have numbness and tingling in their fingers or toes. Make sure it's not getting worse. We know 20% of patients baseline can have peripheral neuropathy. And if I hear patients complaining of more neuropathy, I'll make sure that they don't have any uncontrolled or undetected diabetes or vitamin B, vitamin deficiency, primarily B6, B12 is super important. And then finally, the important role of disease monitoring and health maintenance. Make sure they're partnering with their primary care provider. We're going to need them to help us with their blood pressure monitoring, colon cancer screening, breast cancer screening. These drugs carry an increased risk of secondary cancers, and we can't do it all as oncology nurses. So make sure that they're partnering with their local providers and screening for preventable health conditions, as well as the healthy behaviors such as exercise, activity, socialization, and all of those factors that we want to encourage these healthy behaviors as well. But know that your role as an oncology nurse is an important one as a member of the healthcare team through the assessment and monitoring of side effects, making sure if the doctor didn't order or the nurse practitioner didn't order bone modifying therapy for the patient, say, why isn't this person with myeloma getting bone modifying therapy? They have an increased risk or history of DVT. Why aren't they on any blood thinners? So you can use your voice and speak up to help support your patients. You're also have an important role in patient education, care navigation, especially in the transitions of care with the bispecific antibodies to the community and academic centers, as well as CAR T, and then in terms of psychosocial support. So let's go into the frontline care of patients with multiple myeloma. So, what do you need to know as a nursing? What are some of the insights for the anti CD38 antibodies? So, we talk about quads, and that's not your quadricep muscles. Those are quadruplet therapies. We use 4 drugs now to treat patients with multiple myeloma. Back in the day, in the early 2000s, we had 2 drugs, maybe bortezomib dexamethasone or lenalidomide dexamethasone. And now we have studies that show the Perseus studies, which was daratumumab, lenalidomide, bortezomib, dexamethasone, or DARA-VRD. And then we have the benefit and the IMROZ study that looks at isatuximab, bortezomib, lenalidomide, and dexamethasone. Again, transplant eligible or transplant ineligible. We know that finding the right dose of the 4 drugs, a low dose is better than no dose, but the combination of different mechanisms of action is what's putting patients in remission, keeping them into deep remissions, and that sustained remission will keep them in remission longer. Now, let's discuss this case. There are some other BCMA options in early relapse, and let's think about Matthew. He's a 77-year-old man with a high risk multiple myeloma, relapse refractory multiple myeloma, and a performance status of 2, progressing after daratumumab, VRD induction. He had a stem cell transplant, and then he's on lenalidomide maintenance. So that makes him lenalidomide refractory if he's progressing on that agent. He does have several comorbid conditions, including some renal dysfunction, and he's also in a rural location. And although he can't travel, he lives alone and does not have a full time caregiver. So, what do you consider here? There are so many therapeutic options, but in early relapse, relapsing on lenalidomide, can an off the shelf BCMA therapy be an option for him in a rural community? Could this be considered, such as belantamab mapadotin, or any of our other ones, linvoseltamab, or teclistamab, or elranatamab? And is CAR T optimal or not with his renal dysfunction? I would definitely recommend he at least gets an opinion at a CAR T center, but an off the shelf product might be the best in his case. The answer is yes. So we want to find the right medication at the right dose at the right time for the right patient. And that's a main principle for safe delivery of care of any drugs, including the anti CD38 monoclonal antibodies. So things to think about. So the CD38 is loosely expressed on plasma cells. And I explain it to my patients that this is a smart bomb. We give daratumumab or isatuximab, which is that smart bomb that targets CD38 and causes the myeloma cells to die. So when patients hear that this is immunotherapy, it's not really chemo, they're not going to lose their hair, get really sick in the hospital, then they're a little bit more calm about hearing the fact that we're recommending 4 drugs plus a supportive care because it can be overwhelming. We want to start them on shingles prevention. Even if they had a shingles oxer vaccination, the shingles vaccine was only given to patients in clinical trials that were not on active immune lowering therapies such as chemotherapy. So for that reason, we still might recommend the shingles vaccine, but they're also going to need to be on acyclovir or valacyclovir prophylaxis most of the length of time they're on treatment. We also want to recommend the appropriate premedication. Acetaminophen, diphenhydramine, dexamethasone, and montelukast are commonly administered drugs for our patients. And some clinics will also give medications such as famotidine, which is an H1 blocker, and that will not only help their stomach from the dexamethasone, but it's a histamine blocker, and so that'll prevent the risk of reaction. We used to see a much higher incidence of infusion reactions with daratumumab when it was given IV. Now that it's given subcutaneously with the hyaluronidase, you see only about a 6% infusion related reaction. But you do monitor, and we'll talk about that in a minute. Pre-therapy blood screening is important because we want to make sure, do they have a hepatitis B surface antigen antibody, core antibody positive, hep B core antibody positive. If they have that, then we recommend a medication called entecavir to prevent a reactivation. And I usually link my patients in with gastroenterology to help monitor them. Doesn't mean they have hepatitis or will get hepatitis. We're trying to protect them from hepatitis. We also want to do a type and cross blood match. So daratumumab and isatuximab are CD38 are loosely expressed on red blood cells. And so when you do a type and cross match, that can be interfered with. Also, it interferes with the response. They're always going to see a little IgG kappa in their blood with their on the isatuximab and the daratumumab. So making sure that you know their pre-blood type and then we can watch this over time is important. I always notify the blood bank as well when our patients are on daratumumab or isatuximab, anti-CD38 monoclonal antibody, in case they need an emergent blood transfusion. We have that type and screen, and we let our patients know what their blood type is. And then if it's sub-Q versus IV, we do an observation period 4 hours after our sub-Q daratumumab infusions, injection, sorry, sub-Q, and then the isatuximab, we monitor them throughout the actual infusion time. Again, it's 4 hours is our standard of care for the first one, 2 hours for the standard of care for the second one. Some institutions don't do it at all, but I don't feel comfortable doing that. My institution still supports, and the patients are fine. They'll watch TV, they'll relax, it'll be okay. And then we know that each chance of an infusion related reaction is like 0.2% that second time if they didn't have one the first time, and then essentially zero. Again, these medications are attacking the B cells and the plasma cells. It can cause some hypogammaglobulinemia. So the patients might need to have IVIG replacement if they have low serum IgG levels that drop below 400. CD38 quads have a consistent safety profile. I already mentioned some studies. There's a Perseus study in transplant eligible patients where they did the DARA-VRD and then they consolidated with a transplant and then they had a maintenance. We saw that there wasn't any major increased discontinuation rates. There wasn't a significant increased risk of an infection, and there was not also a significant increased risk of cancer. Again, in this study, 6% was the infusion related reaction rate with the daratumumab. Of course, we didn't see that with the bortezomib arm as expected because it's not a CD38. In the IMROS study with the isatuximab, bortezomib, and dexamethasone, again, the CD38 with the VRD, ISA, again, very well tolerated. They did have some cytopenias in this study, but infections weren't significantly increased as well as cytopenias. Looking at the anti-CD38 antibody dosing, it's highlighted on this slide. Currently, daratumumab, as I mentioned, has been approved by the FDA since 2020 for, pardon me, the use of, they used it with the hyaluronidase subcutaneously, and we are working on a formulation for isatuximab with this on-body device or OBDS. There was an Arachlia trial that was presented in ASCO and EHA, European Hematology Association meeting in June of 2025 that showed that patients actually really enjoyed the on-body device system. It has a small, like 30 gauge on-body device, so it tends to be pretty comfortable. It's given in the infusion suite, but might have the opportunity in some centers and down the road to be given in the home. Again, IV daratumumab is not given routinely very often. It has a higher infusion related reaction rate and a longer chair time, but we can split dose cycle 1 and 8 and give over 1 or 2 days, as well as with the isatuximab. So, what are some dosing strategies to consider for safe delivery of these drugs? So, again, remember, daratumumab's the CD38, isatuximab's also the anti-CD38 monoclonal antibodies. Again, we're already building in a lower dosing schedule. There is weekly for 8 weeks. Starting week 9, it goes every other week, and then it goes monthly. Isatuximab goes weekly, and then it goes every other week continually. So again, you're getting that decreased schedule and a maintenance schedule built in. Lenalidomide, we've dose reduced for if you have creatinine renal dysfunction, decreased GFR. Also, if they're just not tolerating it, if they're making them tired or whatever, we can dose reduce that drug, or if you're having cytopenias. Bortezomib, we tend to try to encourage for many patients to take about 4 to 6 cycles, but depending on response rate, they might need to be on it longer for disease control. Again, if you have a high risk disease, it might be a little bit different. And then dexamethasone, there's this whole down with dex movement. I've been on a couple papers that I've written on the fact that we just give too much dexamethasone for too long for patients. It causes mood swings, hyperglycemia, and all kinds of endocrine problems long term. And so, really trying to use enough dexamethasone for disease control, enough dexamethasone to minimize hypersensitivity reactions. And then, if their disease is so well controlled from these effective medications, we can go down on the dose of dexamethasone or even eliminate that dexamethasone based on side effect profile. Let's go into our next section about early relapse in multiple myeloma, the CAR T pathway, and the role for the off the shelf therapies. So we have current guidelines, primarily the NCCN guidelines, that suggest that CAR T cell therapies are recommended for early relapse. The used to be that you had to have 4 prior lines of therapy. So when these drugs were originally approved, the ida-cel and the cilta-cel for relapsed refractory multiple myeloma, you had to have more prior lines of therapy. Patients weren't likely to make it to that CAR T cell because it's a long process of, we'll talk about that in a moment, of getting them to a CAR T cell center, getting their T cells out, and then manufacturing them. And so patients didn't always have the time. Now we have data from the CARTITUDE-4 and the KarMMa-3 studies that support earlier treatment. So for CAR T, patients only need to have 1 prior line of therapy, including an immunomodulatory drug, a proteasome inhibitor, but have to be refractory to lenalidomide. So, for example, if they had VRD induction about 4 years ago, transplant, and then um, R or lenalidomide maintenance, and now they're progressing, that patient can have a CAR T cell therapy. Do you remember that earlier on we talked about how patients had attrition after their first line of therapy? Many patients didn't get to a second line of therapy in the community. And now this is an opportunity to say, hey, gosh, these medications are so effective. Let's try to get them to the CAR T cell center for an opinion. Now, the idacaptogene viclucel or ida-cel is approved after 2 prior lines of therapy. So they have to have had a CD38 monoclonal antibody with the IMiD and the PI before they would qualify for that CAR T procedure. So, what happens when a patient gets CAR T? So, first of all, I had to get to the CAR T cell center. So, just because a center does a stem cell transplant procedure doesn't mean that they're going to do a CAR T or cellular therapy procedure. What we're doing is we're collecting T cells that are then enriched, genetically modified using a lentiviral vector to express a chimeric antigen receptor or a CAR that targets BCMA. So, it's like a living drug. But this process takes about 4 to 6 at least weeks, if not longer. So think about that person that is progressing with their myeloma and you get them to a CAR T cell center. They have to get screened and cleared through the insurance with a letter of medical necessity, and then they present for leukapheresis. Similar procedure, the apheresis machine, like they do in harvesting stem cells. They don't have to have had a stem cell transplant, but they could have had a stem cell transplant. And then that's when they do the manufacturing. These cars are manufactured in an offsite location in many instances. There's different areas of the world that are doing their own cars in the institution, but for most myeloma, like the cilta-cel and the ida-cel that's available, it's shipped off sites and then it's shipped back to the institution after about 4 to 6, sometimes 8 weeks. And then the patient gets a dose of lymphodepletion. And once the cells have expanded, they continue expanding in the patient. And I explain it to my patients, it's like Miss Pac-Man, you know, that video game where they're just swimming around in the bloodstream, kind of trying to eat the myeloma cells and causing cell death. This is a little different picture or visual of how this happens. I just wanted to highlight this slide though, however, because there's this concept of bridging therapy I wanted to introduce to you if you're not familiar with. So when patients progressing, we'll give therapy A, B, or C to get them back into remission so they can get the leukapheresis in the cells harvested. But then there's also this idea of bridging therapy to bridge that time between the leukapheresis and when they get lymphodepletion therapy and their CAR T cells returned after they're manufactured. So that bridging therapy discussion is really important to have coordination of care between the referral institution and the academic center if there's a different sites of care, because we need to know when do they need to stop their lenalidomide if they're on, or pomalidomide, or when do they have to stop their carfilzomib. And there's different recommendations for stopping. It's usually about 2 weeks before the actual CAR T cell infusion, depending on how well controlled the myeloma is. And then there's short-term toxicities such as cytokine release syndrome, neurotoxicity or ICANS, which we'll talk about both of those in a moment, and then the long-term cytopenias, which can occur. And then we need to support our patients with IVIG, PJP prophylaxis with pentamidine or trimethoprim, so Bactrim, and then acyclovir. And then we also monitor their CD4 counts. Once they get over 200, you can stop some of the PJP prophylaxis. Usually that's about 6 months. So let's think about this case, Dina. Dina is a 66-year-old woman with multiple myeloma. She had stage 3 at diagnosis, some renal insufficiency, which improved, but she had an early relapse after DVRD, induction and consolidation and transplant and R maintenance. So she had that quad, best therapy we could give, but she's got kind of high risk features now. And so we want to be pretty aggressive with Dina and make sure she gets the best Cadillac of a therapy that she has access to. And spikes went from 0 to zero point 0.5 to now 1.5 pretty quickly. And so now we are like, you know what? As this is progressing, we need to do a CAR T cell. She's a little bit scared about the side effects and asks, what can I expect for toxicity? So be aware that some of the major toxicities are short term and long term, as I mentioned on that previous slide. The cytokine release syndrome, ICANS, or immune cell effector neurotoxicity syndrome, infections, and cytopenias. Again, with the ide-cel and the cilta-cel, it's pretty similar that you can get the CRS and ICANS and infection risk with all of these at various intervals, but they're all pretty common. Let's start with cytokine release syndrome. What happens with cytokine release syndrome? Uh, when you're giving this CAR T cells, it's going to stimulate an immune response. And I explain to my patients, it's kind of like when you get a flu shot, you feel a little achy. It's just way worse. And so it mostly causes a fever. That's the number one hallmark of our grading system for CRS is a fever. So you can't have CRS without a fever of over 100.4. Most people will get a little shaking chills. When that happens, we're going to jump right in with the dexamethasone and tocilizumab. Earlier on, we worried that the dexamethasone would turn off the CAR and make it less effective. And that was based on lymphoma studies. But in myeloma, we don't think that's a worry. We'd rather stop that cytokine release syndrome so it doesn't progress to hypoxia or hypotension and land them into the intensive care unit. It is manageable. Again, we know better how to manage the CRS events. Getting good disease control with bridging therapy ahead of time, studies have shown that that can help. So make sure that your patients are adherent to therapy before they get the CAR T. And then also make sure that the nurses know in the hospital, the patient knows to report any symptoms of fever, shaking, chills promptly so that we can turn that off. The neurotoxicity with CAR T remains a big concern. It can range from mild confusion, headaches, to expressive aphasia and delirium. We have a short term ICANS that occurs in the hospital. We're not sure how or why it occurs, but it tends to be cytokine mediated. IL-6 is a major growth factor for myeloma cells, interferons, those can all explode and cause this cascade of these cells exploding and causing the neurotoxicity. We do a neurotoxicity screen about every 8 to 12 hours in the hospital, along with vital signs, and they ask questions like, can you count backwards from 100? Can you write a sentence? Can you look at a clock? And those types of factors, you assign a score, and 0 to 10 to look at how much impairment they have. We we don't give tocilizumab for ICANS only if they have CRS. Corticosteroids are the first line treatment. We also want to do supportive care, IV hydration, and levetiracetam or anti-seizure drugs are recommended. So the NCCN also recommends CAR T cell therapy for heavily pretreated patients. As I mentioned, it was initially approved, this CAR T cell therapy, for heavily pretreated patients after 4 prior lines of therapy, But now we are trying to move the BCMA directed CAR T cell therapy earlier on in the treatment trajectory. We also know there's also these things that are off the shelf, the bispecific antibodies, which will be discussed in the next module, that are also available for patients to receive. Accreditation 1 is the study that looked at patients with heavily pretreated multiple myeloma, and we just had an updated abstract at the American Society of Clinical Oncology meeting in 2025 June that showed that a third of these patients that were heavily pretreated, that historically would have only had a less than 6 month survival rate, are still in an excellent remission with this MRD assessment, minimal or measurable residual disease. They have very little evidence in their bone marrow of multiple myeloma, and they're still in remission 5 years out. So these potentially life extending therapies. And when I was at the EHA and other conferences in June this year, we were talking about cure. Is this a cure for myeloma patients being in remission for 5 years off of therapy? Not necessarily yet, but we're approaching a cure. And if somebody like Dina has access to CAR T and she's progressing fast, then this might be the best therapy for her. So, what are some key take home therapies for delivery of CAR T in myeloma? So, adequate pairing is essential. It takes a while to get to the CAR T cell center. They do the letter of medical necessity. Then you have to harvest the T cells. Then you have to manufacture the T cells. So, this process can take 2, 3+ months depending on the insurance and the patient. So, start that process as soon as possible. So, if you're in the community, make sure that you're partnering with an academic institution and you can share your patients. Consider the implications when planning for use in earlier lines of therapy, such as the bridging therapy. And then the nurses are so critical to support the patients in decision treatment. And so, using HealthTree as a resource and using these types of programs as a resource, you can discuss this with your patients. Avoid the prophylactic dexamethasone or systemic corticosteroids if you can, or prior line alkylators for CAR T cell therapy, and then be familiar with the CRS or ICANS, whether you're in the hospital or not. Now we're moving these therapies to the outpatient. So stay tuned because we're going to have more evidence on how to do that. And don't forget to consult our practice aid for a takeaway summary of practical recommendations. So let's talk about this next section, BCMA ADC therapy. So what's the next step? Let's talk about Matthew. Matthew is a 77-year-old man. He's got high risk relapsed refractory myeloma and a progression of performance status of 2. So he's still kind of fit, getting out of bed most of the day, doing some work around the house, but he's progressing after daratumumab, bortezomib, lenalidomide, and dexamethasone, stem cell transplant and maintenance. Again, somebody who's progressing early, they shouldn't do that. That should only be 20% of the patients should be high risk by calculation, but unfortunately, Matthew is one of them. And he's rural and he doesn't have a full time caregiver and he can't really drive very often places, but can an off the shelf BCMA antibody drug conjugate be considered in this case? Well, hopefully in the future, we talked earlier on in this module about belantamab mafodotin. Belantamab is a BCMA targeting antibody conjugated with a cytotoxic payload that delivered to the cells and makes the myeloma cells die. It causes antibody, it's engineered for ADCC and causing cell death in a variety of functions, and it's off the shelf. The thing about belantamab that I find attractive is it doesn't require a pre-medication with even Tylenol or dexamethasone. We use dexamethasone for tumor control and myeloma control, but you don't need it for hypersensitivity. Also for belantamab, it's a BCMA drug, but you don't worry about CRS. You don't worry about ICANS, and you don't worry about long-term infections. So for somebody like Matthew, an antibody drug conjugate might be right for him if he can stay in the community and get that drug there. We did use belantamab by itself every 3 weeks at a various dosing schedule, but now we have a study called the Dream 7 study. There's also a Dream 8 study in combination with pomalidomide, but the Dream 7 study showed belantamab adding to bortezomib and dexamethasone improved the progression-free survival. They stayed in remission longer than the other drug, DVD, daratumumab, bortezomib, dexamethasone, and they had a longer overall survival. So it's a very attractive option for somebody like Matthew. When we had the drug available before, there was a concern about ocular toxicity. So through unknown mechanisms, people can get decreased visual acuity, and you can kind of see these corneal effects or the eye effects early on through an ophthalmology exam. So the patients had to get the eye exam And then we had to submit it to a portal for REMS, or the Risk Evaluation Mitigation Strategy Program. And then they were able to get the belantamab if there wasn't a decreased visual acuity. And then we just watched them. We tried various dosing things such as dexamethasone eye drops or cooling eye cooling things, and didn't seem like anything really helped. But if you hold the dose of belantamab, reduce the dose of belantamab, or reduce the frequency, patients can still stay in remission. The BCMA therapy was quite effective and stayed in their system quite a long time. In the Dream 7 study, again, taking the learnings from the prior way we used to use it, that's kind of how it was modeled. You can dose reduce pretty quickly and then extend the dosing interval. So we did see in the Dream 7 study, 79% of patients experienced an eye-related event, which is what we're calling it, and blurred vision was the most frequent, but it tended to reverse with holding at the drug. The discontinuation rate was about 10% too. So, when discussing Velamaf with patients, again, it's not readily available. There's still some patients at many institutions on this through an expanded access program, but we'll have to stay tuned for what the FDA approves if it becomes approved again. And it's probably going to include a baseline eye exam to check the visual acuity. And then you get the first dose with the preservative free lubricant eye drops, not steroid drops, just the lubricant free eye drops. Make sure they don't wear their contacts. I also encourage them to try to find alternate driving situations. There's a lot of rideshare services available, or a, a caregiver available in many cases if they can do it. And then we can do with the eye exam in the second and third and subsequent dosing. But so we'll see what happens with the approval process if it is approved. Fingers crossed it comes back, because I think it's a great drug option for our patients. So, what are some of the dosing principles? Again, the dose is 2.5 milligrams per kilogram. It's given intravenously on day one of a 21-day cycle. So, every 3 weeks they come in. It's not every week or every other week. It's every 3 weeks. So, it's pretty convenient until unacceptable toxicity or disease progression. And you can reduce the dose to 1.9 milligram per kilogram. Again, in combination with bortezomib and dexamethasone, it seemed to still be quite effective for the patients. The dose of bortezomib was days 1, 4, 8, and 11 on a 21-day cycle. In the clinic, in reality, we sometimes give it weekly, the bortezomib. So we'll have to see what the FDA prescribing is, and what is recommended if this drug comes back in combination with bortezomib. And then the dexamethasone is 20 milligrams IV or PO the day of and after the bortezomib, similar to how we've done in earlier clinical trials. So now we've talked about the BCMA in the earlier relapse. What about the bispecific antibodies in later relapse? We set the stage earlier on to say, okay, CAR-T is a BCMA-directed cellular therapy. We're manufacturing cells to be a living drug, and that takes time. But what about patients that can't get a CAR T cell therapy, or they're not fit enough? They don't have a caregiver. We will oftentimes recommend a bispecific antibody. There's 3 approved: elranatamab, teclistamab. Those are the BCMA directed, and then talquetamab is the GPRC5D bispecific antibody. A lot of people are asking me, like, okay, so how do I know which one to give? We'll talk about that in a moment. I really don't know, but there are many different things we consider when we discuss what to give to a person when. So let's think about this heavily pretreated patient. Pamela is a 78-year-old woman with triple class refractory multiple myeloma, and she as well has high risk genetics. These poor patients are like so risky. But good thing we have these drugs that we can give to them that can keep them in remission, hopefully longer than maybe the therapy before. She's progressing after 4 lines of therapy, so she's a perfect candidate for a bispecific antibody. She has limited family support, but she does have access to her local clinic. Her most recent progression was very rapid after 3 months. So you really need something that's off the shelf, meaning we can just write the prescription for it. We don't have to manufacture a cellular therapy, assuming she can't wait for CAR T cell therapy. So let's talk about teclistamab. So teclistamab, BCMA directed bispecific antibody. It's the BCMA, binds on the CD3 like a helping hand, brings those cells together and causes the myeloma cell death through cytokine response. So you do get the risk of cytokine release syndrome, ICANS, neurotoxicity at a lesser extent, usually, than the CAR T cell therapies. But as a result, we have these REMS program, the risk evaluation mitigation strategy, which says we should watch our patients for 48 hours after each dose. So in some centers, that means admitting them to the hospital and giving the dose every 48 hours in the hospital. In other centers, you can give them outpatient if they have the mechanism and the setup for outpatient administration. But teclistamab patients are tending to be admitted from 7 to 9 days at my institution. So you got to think, okay, with this lady who's a candidate for BCMA therapy, want to come to the hospital for 9 days. So you have the step up baby dose one at 0.06 milligrams per kilogram on day one. And then about, 2 days after, we get this little higher dose, zero point 0.3 milligrams per kilogram. And then we give the treatment dose. And then you would discharge them, and then they come weekly. And sometimes then we could go every 2 weeks, depending on your institution. Again, look to your institution normals. The step up dose is varies again days 1, 3, and 5. A lot of the centers are going to. Again, it depends on reimbursement, whether you're outpatient, how fit is your patient. But we can give biweekly dosing every 2 weeks for these patients. We worry about infections, CRS, and ICANS. We'll talk about that. Elranatamab. We have a day 1, 4, and 8 dosing. And the interesting thing about elranatamab, also a BCMA times CD3 bispecific antibody. Step up dose 12 milligrams is the baby dose day one. Then you could do step up dose 32. And then in my institution and many other institutions, you could send them home with monitoring of vital signs at home, CRS risk at home. And so they have a shorter hospital stay with the elranatamab. The first treatment dose is 76 milligrams. They stay on that Q-week dosing, and then can eventually go to every 2-week dosing. Again, it depends on your physician, it depends on the practice, and it depends on the patient, how well they're tolerated it. Talquetamab is that GPRC5D, so it doesn't have as much of the BCMA attack on the B cell maturation antigen, which causes an increased risk for infections in a lot of our patients, but it's expressed on keratinized cells, so you get a lot of dermato-oral toxicity. That step up dose, and again, the hospitalization is about the same 9 days. Step up dose 1 is at 0.1 milligrams per kilogram. Step up dose 2.06, and then you can go to the Q week or the Q2 week dosing. All of these drugs get pre-medicated with dexamethasone. We use famotidine as an H1 blocker, a diphenhydramine H2 blocker, and then acetaminophen to prevent Tylenol. And again, at the first sign of CRS, we'll give tocilizumab and dexamethasone. Interestingly, the NCCN guidelines just were updated to include prophylactic tocilizumab. So if you wanted to give this as an outpatient administration, you could give, I call it Profitosi, prophylactic tocilizumab as an outpatient with the dexamethasone if the insurance approves, if that's part of your standard of care at the hospital. So stay tuned. You might see that more often in your hospital setting. So again, you still have to monitor these patients 48 hours, and sometimes it's in the hospital, sometimes it's outpatient. So what's the difference of CRS with the bispecific antibodies versus the CAR T cell therapy? Well, it tends to be more grade 1 with just a little bit of a fever. Again, that's when you give the dexamethasone, tocilizumab, and then continue the T cell engager therapy as their symptoms resolve. And then the grade 2 is a little bit more where they have the hypotension, they might need IV fluids. And so keep an eye on that. And then grade 3, they're in the intensive care unit, vasopressors. Again, it's lower incidence of the grade 3, most of the grade 1 or 2 with bispecific antibodies these days. The key principles of infection are very similar than with CAR T. We want to make sure they're up to date on their vaccinations. Remember, no live viruses, vaccines. We want dead vaccines for our patients whenever we can, whenever they're on immune therapy. We do the HBV testing, CMV testing, especially if they had a prior CAR T, because you can do a BCMA CAR T and then give them a therapy in between, and then they relapse again, and you can give them a BCMA or GPRC5D antibody. So again, one of the questions I get is when to give a BCMA versus a BCMA. We try to avoid going back and forth directly. We want a little bit of time in between, and we want to see what worked before, what didn't work, and what are the patient preferences. So going back to the viral testing again, making sure HBV, CMV, acyclovir prevention, and then the prophylaxis with the PJP, especially if they're on the BCMA, teclistamab or elranatamab. And then, of course, hypogammaglobulinemia, a serum IgG level of less than 400 is recommended for these patients to take the IVIG. The difference with CAR T, I don't think I remember to mention it, but it's regardless of IgG level, they should be receiving IVIG, and it varies per institution, but the guidelines also vary about every at least up to 6 months, sometimes longer, till they get immune constitution. So be prepared to adjust the GPRC5 detail quetamide related bispecific side effects. Dysgeusia can occur. So we do baking soda and salt water rinses, sometimes dexamethasone rinses, but that can be quite expensive for patients. Adding flavor to foods, and then just trying to get them to take an adequate calorie intake. You sometimes see a little bit of dysphagia. Again, the oral and skin toxicities are the most distressing, that the food just does not taste the same. We're now noticing some more skin toxicity. It tends to be very early on. The skin will, it's got like a hand foot syndrome where there's hands are peeling, the feet are peeling, but that tends to be dose limiting and short term. The nails falling off though and peeling back can be annoying. You see people walk into the office with like band-aids on their fingernails. And so I try to recommend to do the nail hardeners and keep their nails nice and short. The dry mouth is not common for everybody, but limit alcohol and caffeine intake if you can. Look for thrush. Just look in their mouth. Make sure they don't have a white coating on their mouth. Look for weight loss. Make sure they're keeping in calories. We do nutrition consults for all of our patients, either virtual or in person. And then I already talked about the neotoxicities. Biotin sometimes people find effective to help as well. So preparing for the new bispecifics. So this is where we say on the horizon. So get ready. There's more T cell engagers on the way. So we already have some BCMA directed bispecific antibodies. Linvoseltamab was just approved in Europe, and we're hoping that that IV BCMA bispecific antibody will be approved in the United States. It's got different cytokine release syndrome and side effect profile. So I think it's going to fit nicely in our space. And tentamig as well is a drug that is in clinical development, which we'll talk about in a minute. Trispecifics, the BCMA type and GPRC5D and CD3 antibodies. So this J&J product doesn't even have a name yet, is showing some promise. And then other targets, this FCRH5 bispecific antibodies called Cebostamab is also showing promise. The intentamig, again, I mentioned really briefly, is a BCMA times CD3 bispecific antibody, and it's designed to induce lower cytokine release syndrome, extended half life. So it's early, but the 2 milligram step up dose and modified dexamethasone pre medication showed really promising safety profile. Again, it's early on, but no grade greater than 3 cytokine release syndrome, which is super exciting. We also see that it might differ because it's being assessed in a phase 3 trial with original step up dosing, once monthly therapeutic dosing. So, again, a longer half life. So, it might change the way that we're giving the bispecific antibodies. So, I hope you found this program helpful in your practice. And I just wanted to redirect you and take a step back again and remind you of the HealthTree Cure Hub. This is innovation that powers life saving research. So, HealthTree, again, is directed towards patients, nurses, providers, direct to patient approach, electronic health record connections. There's a lot of components of this HealthTree Care Hub that you might find helpful. So direct your patients to this HealthTree Care Hub, and then maybe you can take a look at it as well. You might even find it helpful as a provider. HealthTree University, save time in the clinic by answering basic myeloma questions. This is the world's largest online multiple myeloma video curriculum. We saw pictures earlier on about Dr. Richter and others that were sharing powerful videos, and we know that there's some basic concepts to complex concepts, meeting patients where they're at. It might be earlier on in the disease trajectory, they might be further along in the disease trajectory, but the HealthTree University does provide important information to them to help augment their knowledge and be an active, empowered patient. So, what are some 4 key take home points? I wish I could list 500 take home points, but I can't. We're just going to go about this slide, that shows upfront quads are now the standard of care in newly diagnosed patients to find the right dose of the drug for the right patient at the right time. And the 4 drugs at lower dose are better than just 3 drugs or 2 drugs for newly diagnosed myeloma. It can improve the outcomes, especially and including older individuals. Early planning, referral, and partnership when CAR T cell therapy is considered, as well as bispecific antibodies, is critical. The BCMA antibody drug conjugates are pending regulatory reassessment, but will, if approved, offer another option in relapsed myeloma patients, particularly maybe in those frail patients that have fewer therapies available. There might not be a CAR T cell candidate. And then bispecific should be part of your treatment planning counseling strategies for relapsed refractory myeloma. And in all cases, supportive care, AE management, don't forget the important role that nurses play in the management and the coordination of care in the myeloma patients. Thank you for joining me today.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, HealthTree Foundation for Multiple Myeloma. This educational activity is supported by independent medical education grants from AbbVie, GSK, and Johnson & Johnson. To access all materials for this activity, visit peerview.com/ZNS860.